Hello, and welcome to a recording of the 2024 Rush Parkinson's Conference, which was held on September 21st this year. However, before we jump to your video, we do want to take a moment to acknowledge our sponsors, without whom none of this would have been possible. So this includes our platinum level sponsors, Broad Street, Movement Revolution, Supernus, Amneal, and Medtronic, as well as our gold level sponsors, Abbott and Kyowa Kirin. We do also want to acknowledge our nonprofit partners, including the Parkinson's Foundation, Lewy Body Dementia Association, American Parkinson's Disease Association, and Davis Phinney Foundation. And without further ado, here is your presentation.
Applause to you all, because I will acknowledge that seeing this topic and choosing this topic out of the three choices that you've got, that is a bold move. Okay, this could be a really, really scary topic for a lot of people, but hopefully we will end with joy and ways to find meaning no matter where you are in the Parkinson's journey. That is really the goal of days like this. That's the goal of our center. So here's the agenda. Here's what we're going to try to go through. I did plan for about 45 minutes. So if we're running late and you need to go right at 2 o'clock, no offense, go ahead. But we'll probably run a few minutes after. So we're going to talk through a handful of things. And before we do that, if everyone has a packet in front of them, turn to the very last page or two. You should have a blank page that just says activity page. And what I'd love for you to do, if you have a pen, is draw a vertical line, cutting that page in half. And on the left side of the screen, I want you to take a minute and try to answer this question. Right now, what gives you joy, meaning, and connection at this stage in your life? And this is for everybody. If you're a care partner, if you're a person with Parkinson's, whoever you are, what gives you joy, meaning, and connection at this stage in your life? All right. Anyone want to shout out an answer that they wrote down? Socializing. Family and friends. Good relationship. Yeah, that could go either way, family and friends, but good relationships is wonderful. Anything else? Grandchildren. Love it. Thank you, grandparents. Playing Scrabble with my husband. I love it. So everyone probably, there are some similarities that people may have written down, and everyone probably has something unique, let alone things that didn't make it in that quick little minute to write things down. I think what's also interesting is we are all, how each and every one of you interpreted stage in your life is probably really different, right? That could be working, that could be related to a role that you have socially, that could be related to your Parkinson's, or not at all, right? Stage is extremely variable. And that's going to be point one, is we're going to talk a little bit about how we stage Parkinson's disease. And Dr. Kirby talked a bit about this morning. So we're going to start over here. So she mentioned that we have this Hone and Yar scale. And this is the staging system that we have for Parkinson's disease. Okay? It's been around for decades. There are new ones coming. I'll touch on those in a second. But what you can see is, if you look at this, this really only talks about movement symptoms. So often, by the time someone comes to us as a movement disorders doc, or if someone comes to a neurologist with a question of, I've got this tremor, or here's what's going on, or is this Parkinson's, we already might be at stage 2. Because often when things are really subtle and just on one side of the body, we kind of brush them away. Maybe this is normal aging. I don't know. Maybe I'm nervous, whatever it is. And so often people are coming in at later stages. And the staging only takes into account our symptoms on one side of the body or both. And if they're on both sides of the body, is balance affected or not affected? And then if balance is affected, well, okay, then are you able to walk on your own, or do you need some kind of assistance like a cane or a walker? Or if balance is so affected that you can't walk on your own or with one of those devices, are you dependent on a wheelchair or bedbound? That's those 5 levels. That's all we've got. And that is such the tip of the iceberg of Parkinson's. So if that's the staging that we have, people will often come to me and say, is my Parkinson's advanced? And this is a really interesting question. This is kind of a pivotal question for my career, is that if we look at a lot of the studies that are out there, lots of drug studies that are presumably for people with advanced Parkinson's, often the average stage in those groups is stage 3. So I am not a mathematician, but if we're calling stage 3 out of 5 advanced, this feels like we're a little bit skewed, right? And we're not even paying attention to stage 4 and stage 5. I will tell you that stage 4 and stage 5 are very much out there, and people can live in stage 4 and stage 5 for a long time, and they have lots of needs, and our staging systems don't really do a great job of that. So we need to do better. And part of the reason we need to do so much better is because we've got a staging system and it doesn't take into account all of these other things that impact people's lives. So this figure has been around for quite a long time, and it echoes some of what was discussed this morning, is that there are these prodromal symptoms: constipation, acting out dreams during sleep, decreased sense of smell, sleepiness, changes in mood. Those are the prodromal symptoms. Those can happen years before other symptoms arise. But as time goes on, if we think just about the movement symptoms, this is a pretty small piece of the big picture. And so when we're thinking about the future, we really need to be taking that broader view. What are all the things that are affecting a person with Parkinson's, that are affecting a care partner and a family with Parkinson's, and how do we plan for all of that? So here are some quick takeaways on Parkinson's staging. Yes, we have a staging system. Yes, your neurologist could tell you where you are in that staging system. And I will tell you, take that with a grain of salt. Because Dr. Kirby said, if you're not on medicine and we give you medicine, you could go from stage 4 over to stage 2 just with medicine. So it is not a fixed thing in your brain. It's a combination of your disease and the treatments that you're receiving. And none of these are perfect. Each stage looks different for each person with Parkinson's. And we don't want to wait for a certain stage to plan for the future. So people will always ask me, what if I wake up one day and? Okay, the dopamine cells in Parkinson's are not unionized, okay? They don't decide that they're going to go on strike Friday afternoon. Sometimes we feel like it. We tell our fellows, be prepared because the phone calls come in Friday afternoon. I woke up this morning and something else is going on. My Parkinson's symptoms are so much worse. There is no cliff where all of a sudden things happen. That's a sign that something else is going on. A urinary tract infection, COVID, another viral infection, something else. There is no Parkinson's cliff. But that also means sometimes people might wait for a crisis before planning for the future. And we're so much better off if we think about things ahead of time. So, thinking about mapping our journey and thinking about the future. So, I always tell people, and full disclosure, as my Tuesday afternoon clinic, I see people with a neuropalliative care doctor. And we are not sending everyone to hospice, because palliative care and hospice are 2 different things. And we're going to talk about that. But one of the things that we talk about in our clinic is, what kind of documents do you have in place? What conversations have you had with your loved ones about what to do as time goes on, if things change, if there are emergencies? So it always feels too early to talk about things like, who is my decision maker? Or what does my living will say? What is a living will? Do I have one? We filed that away somewhere, right? It's in a drawer somewhere, I'm sure. It always feels too early to talk about this until it's too late. And I think this is one of the best gifts that anyone, Parkinson's or not, can give not only to themselves, their future self, and to their family, is to say, here's what's important to me. And the people around me who might have to make decisions know what that is. They don't have to guess and they don't have to worry about if they got it right. So, advanced directives, I think about as we know that in our healthcare system, we might have ideas of what we want. And then sometimes that's not exactly what happens, right? Sometimes the healthcare system just isn't built the way that we want. And so this is my analogy of here's what we would like, but here's where we are. So advanced directives are kind of like our ladder that helps us get where we want to be. So advanced directives are legal documents in which people express their wishes about the kind of healthcare that they want and who will make decisions about their care if they can't speak for themselves for any reason. So here are a couple of the kinds of documents that I'm talking about. So a durable power of attorney for healthcare. This goes by way too many acronyms, depending on which state you're in. In Illinois, we call it a healthcare power of attorney. So this is different from a financial power of attorney. So you can name different people. You can choose your favorite kid. Which one's good with money? You probably want them to be your financial power of attorney. And which one do you think, knows what you want for your healthcare? Maybe they should be your healthcare power of attorney. But this is who I want making decisions. And a living will is what kind of decisions I want. And in very rare circumstances, this is typically very late end of life, we might have what's called a MOLST or a POLST form. So this is actually a set of medical orders that looks like just a bright neon, some colored neon document. And it's kind of a shorthand for emergency situations to tell healthcare providers, I want this, I don't want this, do this, don't do this. So people will often hear about advanced directives or advanced care planning and go, oh, she wants to talk about DNR. That is a tiny portion, and that is something that we only really think about later at end of life. Living wills and all of the rest of this is really appropriate at any point in the journey. So I want to show you some examples, and all of these links, all of this are in the slides. So you've got this all here for you. So here's an example of what the Illinois Healthcare Power of Attorney form looks like. You can access it online. And it says basically, here's my name, here's who I am, here's where I live, and here's the person who speaks for me if I can't. And it sort of goes into detail about what kind of decisions that means. So I have conversations with people every week, and I've often asked people, do you have a healthcare power of attorney? And they're so proud, and they're like, yes, I do. And I'm like, wonderful. And you signed the form? I signed the form. And I'm like, you are so ahead of the game. Do they know? No. You should probably tell them, right? Because, I don't have Parkinson's. My husband does not have Parkinson's. We both have healthcare power of attorney and living wills signed because something could happen to anyone. And I want to make sure he knows, here's what I want, here's what I don't want. And by the way, you're the one making the call, so you should probably know that, right? So make sure your healthcare power of attorney knows that they are your healthcare power of attorney. And Indiana, if we have any folks from Indiana watching this or in the room with us, Indiana has its own separate form. It's structured a little bit differently, but it's all basically the same. You do need to have a witness to sign off on this. Your doc can help you with this. We can print these out in the office and we can do this. A living will is slightly different. So there are some standardized forms, but you don't have to use a standardized form for a living will. You can use one. You can work with an attorney to write your own. You can write specific directions about what procedures you do or do not want. You must have two people to witness it, and your healthcare professional can't be a witness. I don't know who came up with the rules that they can for the power of attorney and they can't for a living will. I don't make the rules. It is your responsibility to tell your healthcare professional if you've put time and thought into here's what's important to me and what I want, and here's what I don't want. If I don't know that that document exists, I can't align with your wishes and your values. So please tell your healthcare providers, bring them a copy, scan it into the system, and then everyone's on the same page. And as time goes on, we always want to reevaluate, kind of dust off every few years, or if there's a big medical change, take out that paperwork and go, does this still feel right? Does this still feel like this is the decision that I would want made? This is the person I want deciding for me? And if so, awesome. And if there's a change, you tear up the old one and you write up a new one. There are forums, and I've put the links in here for both Illinois and Indiana. For some people, sitting down and just knocking out that form feels very easy. For other people, this feels kind of insurmountable. It's really hard to think about these things, and we recognize that. There are some wonderful websites out there that have structured all of this into processes and conversations and questions that you can talk with your family about. So, two that I like are fivewishes.org and the Conversation Project. So, Five Wishes really talks about five wishes that everyone has. Wish one is the who, the person I want to make healthcare decisions for me when I can't make them for myself, which really should say if I can't make them for myself. Wish two is the kind of medical treatment that I want or I don't want, and that's really the living will. Wish three has more to do with end of life and thinking about how comfortable do I want to be. And that seems like an obvious question. I would like to be comfortable. But what that really gets to is if there's something going on and a person has a lot of agitation or a person has a lot of pain, do they prioritize being awake and with their family or their friends, even if that means being in pain? Or would they like to not have any pain, not be suffering from that, even if that means less awake time or somewhere in between? And then a wish for how they want people to treat me. What do you like? What don't you like? This could be things like, sometimes people will put on calming music, and you can say, I really don't like Enya. Don't do any of that. I don't need it, right? Don't aromatherapy me. I don't like lavender. Leave me alone, right? It can be whatever you want, but you can actually think about that and say, what is meaningful and what gives me connection and joy? And what do I want to be part of any of my care? And wish five is what do I want my loved ones and my healthcare providers to know? And this can be almost anything, but for some people, this is a really good prompt for kind of thinking about their legacy. There's something that we tried out in our clinic called dignity therapy, which is an interview where you say, what is most important to me? And what do I hope my family knows whenever it is that I'm no longer here? And we transcribe that interview and provide a document back. And it's kind of a life story that can be shared with family and friends. So Five Wishes kind of coaches people through that, which is really nice. The other website that I like approaches this a little bit differently, but to kind of get to the same end, is the Conversation Project. So if anyone has read books by Dr. Atul Gawande, he wrote, I believe, the Checklist Manifesto and several other great books. This is really coming out of his work. This has ways to discuss decision making, even with folks who have cognitive changes or dementia. There's a Spanish language version of some of this work. So either of these are really great. And I joke that a living will can be as complex or as simple as you want it to be, but it should be realistic. So this was something that I found on the internet, Jasmine's birth plan, but I will tell you as a medical student on OBGYN rotations, we would be told, go in, ask people about their pain. And I remember going into a room and someone handed me a stapled document that said, this is my birth plan. We are not going to use the word pain. Do not ask about pain. She is only going to bounce on the ball. She's going to do this. It was literally pages long of how birth should go. So you can have a living will that details all of that. That may be hard to implement when the time comes, but you've written what you want down. My husband is an OBGYN. I am aware of what happens. This was my birth plan. I wrote it on a Post-it note, okay? And he laughed and he brought it to the hospital. And thankfully they followed the plan. But your living will can also be something as simple as that. I want this, not that, thanks, right? So I mentioned palliative care. Palliative care, I think, has a very bad rep. Part of it is because the actual specialty, when people are trained, they do a fellowship in palliative care and hospice. And so people think palliative care means hospice, and people think hospice means that's it. I'm done, you're doing nothing. And all of that is wrong. So palliative care is a specialized form of medical care for people with serious illness that's focused on providing relief from the symptoms and stress of living with a serious illness. And the goal is to improve the quality of life in whatever time there is. And so palliative care is typically delivered by a team of specially trained doctors, nurses, and other specialists who work together with a patient's other doctors to provide an extra layer of support and really to think about what does the future look like and how can we shape that so that it's consistent with your wishes. So we think about primary palliative care is actually all of us who are not officially palliative care docs doing that work. So this is a little bit of a controversial thought, but until we have a cure for Parkinson's, which I hope is soon, we're not curing it, we're treating the symptoms and we're trying to optimize quality of life. So all of Parkinson's care is palliative care. And we shouldn't just be focused on the person who carries the diagnosis because they are part of a system, they're part of a family, right? And so we should be wrapping our care around that entire unit. But your loved one's neurologist and primary care physician are primary care specialists. They might just not realize it. So you may have to say, you know what's really, really bothering me on a daily basis is not my tremor. It's actually fill in the blank. My mood, my constipation, my sleep issues, my whatever. And if they can't help with that, they can refer you to someone who can. And I put up this graph. This is a pretty famous graph, I think, now at this point, that was published by Dr. Vaughn, who did her movement disorders training here, and Dr. Benzie Kluger. And this is a graph not based on any particular evidence, but this is the idea of when our needs for palliative care higher. And we used to think palliative care is only at the end. And it's really not, as we know that as symptoms change and as time evolves, even at the time of diagnosis, there's a lot of need to talk about how are we optimizing what your life looks like today and how are we planning for the future. So that need should not be confined just to the end, which is where we bring in hospice. That should be all the way along. We should be thinking about quality of life. So palliative care can happen at any age, at any stage of disease, regardless of how good or not so great our staging systems are, and can be provided with curative treatment. So actually one of, I think, the most unbelievable studies that came out in the last 20 years, not in movement disorders, is people with lung cancer, stage 4 metastatic lung cancer, signed up for a research study and they agreed to be randomized. They were either going to be assigned to keep on everything that they were doing, chemo, radiation, even if the doc said, we know that this might only give you days and lots of side effects, or they were randomized to hospice. And hospice is a small fraction of palliative care that is for any age, but someone for whom the healthcare professional treating them feels like there's a reasonable chance that their life expectancy is 6 months or less. And in hospice, we shift away if we have curative treatments, which we don't have in Parkinson's. But for someone with cancer, we say, okay, we're not going to do chemotherapy anymore. We're going to treat the pain, treat the symptoms, treat the other things. And in this giant study where people were randomized to either do everything, quote, do everything, or have hospice, not only did the people who were randomized to hospice have better quality of life, they lived longer. They lived longer because they're not suffering through other things that were only worsening quality of life and giving them side effects. So if nothing else convinces you that hospice is not doing nothing, it's that. It is what is bothering you, what symptoms are you having, and how can we treat them? And so that really is where we bring in hospice, is if we think that someone is approaching the end of life and it is the opposite of doing nothing, it is so frequently doing more. How do you think about these things? What if I don't want to work on these documents myself? So elder care attorneys are a fantastic specialty within law that really focuses on a lot of these things. They can help with financial power of attorney, they can help with healthcare power of attorney, drafting a living will, and even thinking about if a loved one needs to go into a facility, needs to go into a nursing home. That is always, always, always a very difficult decision and a very personal decision. And financially, it is a very complex decision. Planning for that can be really, really eased by having an elder care attorney to help. So that's a lot of in the future to think about then. Let's live in the moment. So, what do we do now? I want to talk a little bit about working and adjusting and retiring with Parkinson's. I would say this is very different for everyone. This is very different depending on your profession, your career, where you are, who you work for, what your work looks like. But know the policies at your place of work. If you are still actively working, accommodations can frequently be made. Know whether you have access to short and long-term disability, explore any work-related insurance coverage and disability policies. And if you're finding that there's something that's really challenging, if you do a lot of typing, but your tremor's getting in the way, right? Asking about, is there a different keyboard that might be ergonomically better and help you? Ask about dictation software, things that we can adapt so that you can continue doing all of the work that you usually do, but without as much difficulty. Additionally, there's something called vocational rehab, which is where you say, I'm really struggling in the job or the specific role that I have. How can I take everything I know and all the skill sets that I have and the abilities I have and transition that to a job where that fits better? So that is something that is open to folks. And we do often get the question, can you help fill out disability paperwork? Yes, your neurologist and your folks can fill out disability paperwork. We are happy to help. One of the things that is like a, no, absolutely, that's wrong, is I hear people tell me, well, we were supposed to go on a cruise, but Parkinson's. No, no, do not accept that. Done. Okay. If there is a bucket list trip, if there is something, if there's a family event and you need to travel to Timbuktu, there are ways to get there. So please, please, please do not accept Parkinson's as a reason to not go on that journey, not go on that trip. There are so many things to make life easier. So people with Parkinson's can fly, cruise, sail, hike, bike, all of the things. It just takes some planning and some creativity and some flexibility. But there are unbelievable services and things out there to help people. I have had folks who are very, very limited mobility wise, wheelchair dependent, wheelchair users, big wheelchairs, custom power wheelchairs on river cruises through Europe. And everything in between. Folks who have not, been able to walk in a long, long time, and the thing that was most meaningful to them was being able to go ice fishing. And we got them out on the ice and we got them ice fishing. It just takes some creative planning sometimes. So think about adaptations and services. So I just highlight every airport has some kind of skycap service. Ask for it, use it. A concept that Dr. Kramer, one of our neuropalliative care specialists, talks about all the time is this idea of energy conservation, which means all of us, Parkinson's or not, have a finite amount of energy every day. Do you want to spend that energy schlepping through O'Hare and waiting in all the lines and standing and sitting and going through TSA? Or would you rather use that once you get to your destination, being with family, spending time walking around, playing with the grandkids? Most people would rather take the hit and not have to suffer through O'Hare, right? And have that energy when they get to their destination. So accept the help because then you can do what you want at the other side. Something that I just learned about. I was traveling to a meeting and I saw all this stuff with sunflowers in the O'Hare in Midway and in Minneapolis. So the Hidden Sunflower Foundation is all throughout the world. And this is a foundation that will, if you reach out to them and say, you don't even have to tell them what's wrong. You just say, I have a disability of some sort that makes it harder for me to travel, and I might need extra time or assistance or patience. And they will send you a little lanyard. It doesn't say anything. It's just a little sunflower. But the staff of the airport is trained to look for that, recognize it, and go, that's someone who might need a little bit more assistance. Let me go help them. So you don't have to volunteer anything. It's just a quiet, silent symbol that says, I might need a little bit of extra assistance. It's brilliant. So the website is there. It's everywhere. This is just taken from their website. And full disclosure, so if people are not aware of the American Academy of Neurology has a magazine that's free to the public. It's called Brain and Life. I'm on the editorial board, so full disclosure, I'm biased. I think it's great. There's a website that goes with it. We've created a lot of content on there with tips and tricks for traveling if you have a neurologic illness. So all of this is in the handout. The other is driving with Parkinson's. I get this question a lot, even from folks very early in Parkinson's. Are you going to take away my license? She's going to take away my license, isn't she? No, I am not. Right? Having Parkinson's is not a reason on its own for someone to stop driving. One of the things that one of my mentors told me years and years ago is this is one of the best, quickest questions to ask someone to get a sense of whether we should be concerned about driving. Ask the person themselves, ask family who's with them, how old is your youngest child or your youngest grandchild? Would you feel comfortable being the one driving with that youngest person in the car? And if there's a pause, if there's a question, maybe we sort of recognize something in our gut is telling us at least there's a change in driving and we should explore that. Does not mean that we just grab your license and take it away and we run out of the room, right? It means if something is happening, how can we address this? How can we rehabilitate to maintain your independence for as long as possible? So having Parkinson's itself, not a reason to stop driving, but having Parkinson's does increase changes to driving, particularly driving in unfamiliar places, driving at night in poor weather with construction or complicated intersections. We know that that's where people with Parkinson's tend to have problems. So instead of just going to the DMV, where it is really a black and white yes or no, we take your license, we let you keep your license, we strongly recommend, if there's a question, there are specific occupational therapy run driving safety evaluations where someone can go and they will test all of the different building blocks that are necessary for driving. How's your reaction time? Can you turn your head in all the directions so that you can look at all the mirrors? And if you can't, well, then they can fix the mirror. That doesn't mean you stop driving. We adapt the car, we adapt the environment. So there are lots of things that you can do. And if all of those building blocks are okay, or if all those building blocks need some help and we get that help, then they will put you on a road test, either a simulation or actually a road test, and they'll see how you do. And if they find other issues that are rehabable, they will rehab them. Only if we really feel like that is not safe will they then write a report and say, this person, is not safe on their own, is not safe to other drivers to continue driving. And if that happens, there are other ways that we can help people get around. We have our social workers who have amazing resources to help us with that. So just something to think about. Similarly, lots of resources out there to read about, to think about these ideas as time goes on. So I highlighted a few from Brain and Life, but there are a bunch out there as well. Very quick plugs in terms of mobility changes. So as people's mobility changes over time with Parkinson's, different assistive devices might be able to help. Folks will often, usually there's like the very well-meaning family member and they're like, oh, I saw an article, I saw a thing, about this fancy walker from Denmark and I'm gonna send it to you. Not all walkers are the same, and some are better than others, and everyone is different. And so it really does behoove you to be evaluated by physical therapy, to be able to identify what's gonna help, what's not gonna help for me. And maybe there's one that's really great for you, and it weighs 50 pounds, and you're not gonna be able to get it into the car. Or I used to take care of patients in New York City. They have to schlep it onto the subway. The walker's not gonna work if it doesn't fold up, right? And so there's a Medicare rule that people should be aware of. So if you are buying a walker and it's just one of the standard four-wheelie things that you can pop the tennis balls on at the end, pay for that out of pocket. Medicare will cover one assistive device, like a walker or a cane, every 5 years, and Medicare will cover one wheelchair every 5 years. If you use the benefit on a walker and you need a wheelchair sooner than 5 years, that's fine. But if you spend it on a wheelchair, you can't go backwards. They'll make you wait 5 years before they will cover a walker. So there are walkers if people are having that freezing where their feet get stuck, or festination where you're running really fast, or people are tipping and falling backwards. There are some walkers that are really good for helping folks with that, and they're very expensive. So pay for the dinky one out of pocket, use your Medicare benefit to pay for the more expensive one. And you don't need to figure this out on your own. We're very lucky here at Rush, but throughout the city, there are seating and wheelchair clinics. So if people need a wheelchair or another device, they can be fitted exactly for the custom one that they need. Um, for the sake of time, maybe I will skip past cognitive changes today. I'm looking at Dr. Gonzalez. Um, so we know that things change, and our neuropsychologists are integral parts of managing Parkinson's. Neuropsychological evaluations, I think sometimes people think I'm going to go and they're going to see what's changed, but this also helps us identify areas of strength, which means that helps us identify what are the compensatory strategies that we can lean on. Where is someone really strong? And how do we leverage those strengths to help overcome some of the challenges and changes? Um, I bring this up only to just think about safety in a couple of ways when we're planning for the future. So, if the person with Parkinson's has hallucinations, delusions, agitation, or dementia, something that you can do that many people don't know about is if you call the non emergency line to your local police station, you notify them that there is someone in this home at this address who has these issues, and they put sort of a flag on that address. So if a 911 call ever comes from there, or if the police are called for any other reason to the home, they approach with a different perspective. They know that they may be encountering someone with dementia, and hopefully they treat that person differently than if they just saw someone who was agitated and angry. They can approach with some understanding and sensitivity. And we know that in the US, over 50% of people over the age of 60 live in a home with a firearm. If someone has Parkinson's and hallucinations or delusions or agitation, that can become really concerning. So we just want to make sure that if we have that, we're taking additional safety precautions to make sure that they're safe. And if impulsivity or wandering are present, or the person living with Parkinson's has unsupervised time on their own, some things to think about are kitchen safety. So taking the knobs off of a gas stove are a very easy way if you're outside, if you're, going to leave them and they're by themselves, to make sure that they don't just accidentally turn on the stove and forget. And making sure that sometimes if someone accidentally has microwaved things with metal, that can be a challenge. Just unplugging the microwave if they are on their own. And there are various different systems for wandering and medical alert systems that can be very helpful. So several of these things, these are all in the slides, but helpful resources. So um, one of the things I get asked a lot, especially in our Tuesday clinic, our Ames clinic, is when is the right time to think about hospice? How do I know if we're approaching end of life? What are the signs? And I will tell you that we are still struggling. We are still doing a lot of research to better understand and to help predict how much longer does a person have? What is life expectancy at X point or Y point or Z? And so we have a few things that can help us. Number one, we always think about if there's a big medical change, make sure that you take out those advanced directives that you've done, dust them off. Do they still fit? And make sure you get updated copies to decision makers and healthcare providers. And the few prognostic signs that we know of in Parkinson's that tell us we may be approaching end of life are repeated hospital stays, especially for severe infections or what we would call sepsis, repeated falls with fractures or injuries, significant unintentional weight loss. So someone is losing 10% of their body weight over 6 months, or their body mass index is dropping, or they've got repeated pressure wounds, or they're sleeping most of the day. Those are things that when I hear that in clinic, that's when I might sort of pivot the conversation and say, it feels like we're at a different place. What do you think? And how do we want to move forward? Um, I know we are running late. I'm going to leave you with the information on hospice. This is all in the slides. Um, And I won't go through the most and the post form, but this is in there. This is literally an example from the Illinois form. The Indiana form has all the same stuff, but in a slightly different color. Okay, so a couple of additional resources and then we will wrap up. We have a ton of great video content that our providers have put together for you. We know that for a lot of people, asking some of these questions about planning for the future can be really, really difficult. And so we often call these the doorknob questions. Is we talk about constipation, we talk about the tremor, we talk about the dyskinesias, we're wrapping up, your doc goes to leave the room, they're literally, their hand is on the doorknob, and you're like, by the way, hospice time? Should we think? And it's like, no, we can't. I'm an hour late. I can't talk about hospice now. But we have content on this for you that you can review at any time. We have videos on how do I know if I should think about bringing in a caregiver? And what would I actually ask them to do? What do they do all day? What am I going to have someone do in my house? A lot of that kind of information. What's the difference between palliative care and hospice? And some of this we even have in Spanish. Thank you, Dr. Gonzalez. So for any of that, the website is included. We have our support groups and our educational events where we talk about many of these things. You can sign up by zapping this QR code and filling out a couple questions. It will get you on the list for the stuff you want to be on the list for. And then a very quick shout out. So the Davis Finney Foundation, which has a table at the fair, they put together a care partner training program that I had the honor to be part of. And this is really geared for care partners, has lots of recorded content about all kinds of topics. If this is interesting to you. Finally, a very biased shout out. This is a study that my own team is running, but we recognize that being a care partner is tremendously difficult and people do not get the support that they need. And especially if we get into caregiving with a loved one who has cognitive change, whether that's Parkinson's disease dementia or dementia with Lewy bodies, this can be really, really difficult. And the people who know the most about this are other care partners. It's not us. It's people who are living this 24/7. You have so much lived wisdom that is not valued in the way that it should be. And so this is actually an NIH-funded study where we are testing out an intervention where we train care partners to serve as mentors and resources to other care partners. And we've created a whole curriculum recognizing there's lots of good stuff on the internet, and there's also lots of crud on the internet. And how do you know what stuff is actually reliable? So we've created stuff and a curriculum, and it's all there for you. So if you are a care partner, if you have a care partner, please feel free to share this. We are enrolling over 600 people throughout the US and territories. It is all virtual. So with that, last couple of things. So we looked at what gives you joy, meaning, and connection at this stage in your life earlier. I would have you to look back at that activity page and what you wrote down. Is there anything in what we talked about today that makes you think, okay, I need to do XYZ to make sure I'm achieving those things or I'm still able to do those things? How can you stay connected to those things that give you joy, meaning, and connection? And then this presentation might have brought up fears or concerns for the future. I recognize that. I hope that you leave here and you can think about steps that you can take now to address those fears, those concerns. What can you put into place to make that easier? I know we're running out of time. I love for people to think about their hopes and their goals for the future. And what can you do now? What practical, actionable step can you do now to help you get closer to those goals? So here are my quick conclusions. Everyone's Parkinson's journey is different. Doesn't really matter what your stage is because your stage could look totally different than someone else's same stage. There are some shared milestones that we can anticipate and we can plan ahead for. There are adaptations and adjustments that can be made for almost anything with help from healthcare and allied health professionals to prolong your ability to work and drive and travel and live and thrive with Parkinson's. And palliative care is appropriate at any point along the journey to help you live your best and fullest life. Hospice is appropriate for end of life care, and is really the opposite of doing nothing. It really is doing everything to maximize quality of life when quantity is short. We have so many resources. Hopefully today was just a small taste of everything that we have for people and care partners. Please ask your team if there are things that you heard about today at any of the talks, any of the stops, and you're like, I didn't know that that existed. Ask someone. We are happy to help. So with that, thank you so much for sticking around. Thank you so much for being here today. We really appreciate you.